We can go back on the record, Mr. Miller.
Okay, we're on.
All right. Mr. Wooden, I'll have our counsel swear you and each of your colleagues in, and then you can provide your presentation from there.
Hey, good afternoon, everybody. So I'm going to administer the oath. Before I do so, just a note, after I administer, I'll ask that each of you just go through, state your name, and then affirm the oath. And as Kristen just mentioned, that way we have a record for the court reporter. Do you solemnly affirm that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth under the pains and penalties of perjury?
Joe Wooden, Administrator CEO, I affirm the oath.
Jeff Hebert, CFO, I affirm the oath.
Wayne Stockbridge, Chief Administration and HR Officer, I affirm the oath.
Jody Legacy, Director of Quality, I affirm the oath.
And Kathy DeMars, Vice Chair of the Copley Board, and I affirm the oath.
All right, witnesses are sworn in. I'll turn it to Copley to give its presentation.
Great, thanks. Can everybody see that?
Yes.
Nice. Technology's working. I'm so happy. Now I can relax. Up until that point, I always wonder if it's going to work. So the folks that are here today, we just swore them all in. Really appreciate your time. I've watched a few of these meetings. There's a lot going on. Hopefully we'll have a robust, helpful conversation here. Very thankful that Kathy DeMars is with us, board chair. Usually the board chair or vice chair shows up to the meeting. I think she's listed as chair, but she's actually vice chair. She used to be board chair. Kathy DeMars has been extraordinarily helpful in the organization over many, many years. And she's also administrative CEO of the VNA, Home Health and Hospice. So she brings a lot of excellent experience as a nurse. But I wanted to ask her if you wanted to make any comments, Kathy, or a few statements.
Yes, this is Kathy DeMars. I just wanted to open up by thanking you all on the Green Mountain Care Board for the work you do. I've sat on the hospital board for 11 years, and I know how difficult it is to make healthcare decisions. And we've made some tough decisions here, and I know you can't make everybody happy. So I really admire the work you do, and thank you for all of that and your commitment to healthcare, in our state. I also want to say that hospital boards right now are making really complex decisions with intense financial and regulatory pressures. So we're a volunteer board, and we really appreciate any support we can get from the Green Mountain Care Board and anybody on the state level for that matter, as we make these decisions moving forward as our healthcare changes and we need to make changes.
Yeah.
So, thank you.
Thanks, Kathy. Okay, and I'll walk through some slides. Here's sort of the table of contents. First, talk about the background and sort of overview of the hospital. This is our mission statement, and these are some of the pillars in the mission statement. It's a great place to work. I feel that way, and I think we noticed that because people who applied for jobs, people who write letters of thanks and appreciation, we get a lot of those. Jody's going to probably talk about that in the end around quality. But it is, we're very happy to be here. I think people take their jobs very seriously, including the board members, some of them that are up here on the slide. So I wanted to just say that our history is wonderful. We like to go back and think about Mr. Copley, Alexander Hamilton Copley, love that name, who donated a lot of money. He wasn't a clinician, but he really helped the town of Morrisville tremendously with the People's Academy. Golf course is named after him. The hospital he started, and it took many years in its wonderful history that the community came together. It took him a number of years to say, we really need a hospital back in 1932, which is pretty exciting. And I think the picture of the nurses, most of them came from way back when, Mary Fletcher. I think they came from Burlington. You can't really read their insignia, but we've been very proud and happy as the hospital has grown for going to come up on 100 years in just a while. I like to show this picture. I give this to new orienting employees. I do collect antique Vermont hospital postcards. Now, talk about being specific. It's a weird collection, but I think it's fascinating in the sense that, remember a long time ago, people stayed in the hospital so long that they wrote postcards to their family and friends. That is almost hard to believe. So this is the old Copley Memorial Hospital. It's a wood structure building. It's just like a 32nd of a mile down the street, pretty much almost next door. And that's now the Lamoille County Mental Health Services, the designated agency. So I do love that history, our relationship to the community. And again, I share this with folks. The one on the right is a food drive. And you gotta love the hospitals in America. Hospitals used to do linen drives where they'd collect sheets, pillowcases, blankets. They really needed the community, washcloths, and they also did food drives. And this is just an example we found because we've got a lot of history. We got a book with every single patient. I think the first 25,000 patients handwritten and typed into a book, which is great. So this is just a little bit of fun. Overview of us, we're an independent nonprofit critical access hospital, one of 8. We're also a member of the collaborative. We're going to talk about that later. Our service area population, I just want to pass this on to everybody as an educational moment. I apologize, but I do think it's important. The old-fashioned HSA, hospital service area, we say 30 to 50,000, but it really is an important denominator when you're doing the mathematical calculations of need or how much of a urologist do you need or what are you doing? The denominator is always, what is your HSA size? And so that I think we should always consider when we're looking at data and numbers to say, oh, you guys have more than enough X, Y, and Z. So that's why we put that range there, the HSA definition. CH hospital, emergency department visits, employees, members of the medical staff, our net operating revenue, and community volunteers. That number pretty much dried up during COVID. We all remember that. We actually had somebody, I'm going to keep her name out of it, in the OR. What was her name? She would still show up in the OR, get gowned up, and would still volunteer. Betty. Betty would show up, and we couldn't stop Betty. She's in her early 80s, and it was very helpful that Betty continued to volunteer. So we're glad to have the volunteers back, which is good. This is part of the overview for new employees. Overview of services. This is updated with some of the older names and crossouts. So if you see up top, OB is being tapered down. We're still going to have OB-GYNs, but they're not going to be doing OB, as you know about the birthing center closure. Urology, we just got notice of that a couple of weeks ago. So that service is going to go away. We don't employ that person. It's been an independent practitioner. That's what happens in small hospitals. We had a cataract surgeon. He's leaving, moving to the Montpelier area, so we no longer have that service. When that happens, we think about, should we try to employ somebody? Should we let the marketplace bring somebody to us? It's always a difficult conversation. It's not that we just go out and say, well, whatever it takes, get another cataract surgeon. So it is kind of interesting. The birthing center and OB we talked about. On the right-hand side, we did close the aquatic therapy pool program as well as sleep medicine, and we'll be showing you that. So this has been a year, actually, of quite a bit of changes this past year in the organization, and they're just difficult. Change is difficult. It's not easy, but it's understandable. Patients served, I think we're a little different than a lot of hospitals because only about 60% of the people from Lamoille constitute our workload. So we have a lot that come from Washington, Chittenden, Caledonia. So if you look at who we serve, again, back to what is your HSA? How many patients are you supposed to be serving? Well, this is kind of our history. This is what goes on. And here's patients by zip code for the FY24 data. We update this maybe once a year, but it's really interesting that people from Barrie or Burlington or Essex Junction or Montpelier, I love the bottom 2 arrows. Other towns in Vermont constitute 17, close to 18,000 total visits being inpatient or outpatient, which is really a big deal. That's a lot. That's the second largest town outside of Morrisville, which is listed up there. They're alpha sorted. So Morrisville's at 23, and our second biggest town that we serve is called Other Town, Vermont, which is kind of funny. And we have out-of-state folks. So, 56 patients that constitute about 2281 outpatient procedures. Another overview, you guys all know this, but it's great to be reminded. This is the way we look and sort ourselves. Academic Medical Center, which is a tertiary PPS. You've got the 8 critical access hospitals on the bottom. We're one of 8. And then the standard PPS, which goes back to 1983, the change in reimbursement that happened. I'm only bringing this up because I think the methodology that we use, which the Green Mountain Care Board has been using by looking at folks by size, it's a great movement in the right direction to say that, because we're all different and unique. But also you could look at hospitals by whether or not they're part of the Dartmouth system or the UVM system, which would make sense. I know AHS lately has had some ideas of how to sort working through RHRC. You could also say north and south makes a little bit difference, just because the southern part of the state is much closer to Massachusetts, Rhode Island, and New York. You could even do east-west, like I said, Dartmouth or UVM. There's a lot of ways to look at how we deliver care and make sense. Here's our size based upon others. It's a very humbling slide. Yes, we are only 3% of the hospital budget spend. And this slide shows that back in 2022, I didn't update this, but I want to show you the update. We were running as a state about $3 billion, which is a big number. When you say the B word, billion, that's like, wow, 3 billion. But when Jeff updated this, Jeff has all the data. I just get to present it. He does a great job. So we went to 3.636 billion in 2 years. I bring this up because I talk about these things with a lot of people and venues. The hospitals alone spent $620 million more in 2 years. And I know we always look at the data to get a sense as to how much in crisis are we, what can't we afford. This one, when I came across it, I was shocked. Given our population size, to say in 2 years, we are now spending $620 million more. It does make us all pause. And I think all the work that you guys are doing and we're all trying to do around healthcare reform, transformation is necessary. I hope it continues, and we might have to continue to be more assertive. Strategic plan, this is our plan. We're going to update it this year. We spent a lot of time doing it. It's important. Can't imagine doing it more than 3-4 years. Sometimes it changes dramatically in 1 year. Our main categories, and I can't imagine they will change ever. I didn't come up with these. It's just a group process, which is finances. And we did put it first with a lot of lament from people to say, oh my gosh, I can't believe you have finances first. Well, the sustainability of Copley and the finances need to be first, because it is front and center a concern. Quality being second. And I'm hopeful maybe this go around with the strategic plan, at least maybe the next time we put quality first and say, finances are controlled. They're always in our peripheral, but they're not front and center, sort of being a huge concern or raging. So those two are always going to be first and second. Workforce culture, of course, for small critical access hospitals, that's part of what we do. We're not a teaching hospital. We don't operate in a bunch of states. So these are all sort of simple: workforce culture and keeping care local. But not all care. Of course, we made a decision, but doing our best job we can, because people would rather not travel when, in fact, if it is relatively routine, simple, and plus it alleviates, the 2 medical centers. And we learned a lot about that through COVID. So as part of the finance chart, I'm not happy with this chart, but it's helpful for us to look at our operating gain and loss at the end of the year. And so we've had a lot of years of losing money. They do add up. It is hard to cumulatively get out of those years, because each year that you get behind, it almost you not only have to maybe pay that back, but there's sort of interest. And that time is not in our favor. As time goes by, everything's getting more expensive, whether it's construction, labor, et cetera. So this is what we struggle with. I know Jeff and I will be talking with this, but that's kind of why finances are at the top of the list. So service lines, want to talk a little bit about service lines. In this one, I put growth and shift up there because that was part of the Oliver Wyman report. And it's easy to complain about that, but the Oliver Wyman study, I think, was always saying to each community and each organization, in some areas you should see if you could grow and enhance and maybe become a center of excellence. In some you need to probably shift, partner, and question, can we afford to do that? So here's one of them. This is from June 2024. It seems like it was more than just a year ago. It seems like it was a lot more than a year ago, but this is some of the reports, and this is where Copley is noted in some of those yellow charts, grow or shift birthing to other organizations. I think it's a nice way of saying it, but when you dig into the data and ask people and read between the lines, I think directionally Oliver Wyman has helped us look at these things. Second one is become a regional referral center for orthopedics, something that I think we've done and will continue to do. So that one is sort of grow that, make sure you continue with that. And the right-hand side is execute on shared services with other hospitals. I think we're doing that very well. There's a group of us, and I'm going to talk about that a little bit later. And, even strongly consider formation of a regional specialty medical group with other hospitals. We're also considering that. That's a lot more complicated, but I like that it's out there, and it's a suggestion that how can you folks work closer together, almost like a network, the independent hospitals. A couple of other slides with the COE. We love our initials in healthcare. Sometimes it drives me even crazy. Center of Excellence. And so down on the right with Copley, it's sort of a suggestion about orthopedics. Continue that, or make sure that maybe we all recognize that, which I think is great. Above that's neurology. We actually have a community neurology service that does well. So it's not that we would end that. It's hard to even find a neurologist. I love all these ideas, but you have to sort of look at the circumstances, people that you have. And we also have a very active and renovated infusion therapy chemo unit. So just mentioning those. Service line reductions this past year. Again, some of these have been intentional. Some of them we just experienced. The sleep medicine services, we did seriously look at that. What are the volumes? What are the expenses? And it comes down to recruitment of staff, retention. We need certified overnight sleep technicians, medical director. So we were using travelers and locums and found people that could help us in terms of the MD side. We even had a traveler, I think, on the sleep technicians. It just became not helpful. I know there's some need out there, but we really couldn't continue pulling that off. The aquatherapy program, we again had low numbers, volumes, expenses with that. I think the pool liner alone replacement is $40,000. We got that in the mid 2000s, and at that time there was not outpatient orthopedic surgery as it is now. Pretty much like 90 to 95% of all of our orthopedic work is outpatient, so that the pool therapy program, either prehab or post, is really not used, and so we made a decision to close that. Cataract surgery, we had Dr. Doyle working with us. He was great. Everybody loved him, but I think he's moving towards the Montpelier area, so we're not doing cataracts, and we're not aggressively looking to replace that. We just sort of wait and see. And if somebody moved into our area from wherever and said, "Oh, I now live in Stowe or Morrisville," then we would be like, "Great, let's talk to you." And then the birthing center, which everybody probably knows about, was a really huge decision. And I'm going to comment on some of that going forward. This was the chart that finally got printed in the newspaper that people saw. And I think a lot of people, it was eye-opening to see the percentage of drops that we had that were significant going back to 2006. We do have some data going back that gets a little bit squishy and a little bit gray. But the issue of whether or not we should continue with the birthing center, prompted by Oliver Wyman, but never in our strategic plan. We never actually really thought about this. And when it was brought up, we said, yeah, I guess we really should look at this. And we found out, I know Kathy's been in the community a long time, but she hasn't been on the board for 25 years. But we found board members and others who would say, oh yeah, over the years, you guys have looked at this a number of times. I don't know, I think the count was maybe 3 or 4 times. We had people say, yeah, we looked at that back in the 2000s. We looked at it 2010. We looked at it again. So this was helpful to see at least that trend. The other thing that ended up in the newspaper, which was helpful, sometimes the newspaper can be looking for helpful. Sometimes they're just looking for stories. And this is just sort of what's the birthing center number of births, and that number fluctuates. Sometimes it's 170, 180. It's been going down lately. But so that's just a perspective about all the other work that we do, and I thought that was helpful. Now, this has been a very difficult discussion. I will tell you that. This is probably one of the most difficult things I've gone through, having worked at 6 hospitals, been a CEO at 4 of them. But I'm going to let Jeff talk about the quick financial data, and then we'll talk a little bit more about the decision making. So this is just one chart.
Just one chart. So the data up on the screen, to actually do this analysis of our birthing, we utilized our 2023 cost report data. We actually worked with Helms and Company to validate that data and all the assumptions that went along with that data. We also had some opportunities to reach out to other organizations that went through the same process. And when we actually saw how they did it, it was very similar to the approach that we utilized. So going up onto the columns, I'm going to try to explain the hospital department. Those actually represent the hospital's birthing unit, our L&D department, and our nursery. The next column over is our outpatient clinic. This is the area where our providers and APPs are expensed and the revenues recognized. And then the next column over is our OB ancillary. We actually needed to understand which departments actually benefited from our births. And those departments would be like our OR, our radiology, our lab, and et cetera. Moving over to the next area, this is the partnership option working with Helms and Associate. And what this option was is we would work with other hospitals, and Copley would do the ante and postpartum care, and Copley would also keep its GYN services. And so moving down the total impact, that last column, our net revenue with this change is coming in at 1.1 million going down. And our total margin in this study was removing 2.9 million in margin. The data that is in our budget is actually 11 months, whereas this data is 12 months. And the other thing is we also, for 2026 budget, did put in closing costs, which include the possibility of using additional locums, travelers, working with our community relations departments, et cetera.
So we actually studied and called a number of hospitals to find out who went through this, what did it look like. When we first addressed this with the board, it immediately became a very emotional and difficult issue, and staff, others. I know our nurses union got involved and I think coordinated flyers, and this was a really difficult process. On the bottom right, it's got 2,732 signatures. The problem became save the birthing center. Don't even have the discussion. Take away the decision-making process by ginning people up to say, you've got to prevent the closure and save the birthing center. It made it really difficult for all of us, the board. We did hire the outside consultant that Jeff was referencing to really make sure that, the Oliver Wyman report was prompting they had some suggested minimum births for a hospital. If you go below that, sort of questioning whether or not you should do that. Our HRC also had some minimum births. Healthcare does not like volume requirements, but this was really, I've never seen anything like this, and it felt really disrespectful to the board who ultimately makes the decision. You know, we make a recommendation, but the board really, we had somebody quit the board.
Right.
I don't know.
It was incredibly stressful for the board, and we each personally received probably over 200 letters to our homes from various people, and some of them were not very kind.
Yeah,
So it was very stressful for the board through the whole process.
it became really discouraging. And again, we lost one board member. Others were just like, you know, I really appreciate the hospital. I love it, but this is overwhelming. And then we had the rallies, you know, save the birthing center, let's not close it. And we're in the middle of the process of understanding this, again, knowing that this has been done 3 or 4 times in the past. And it came down to us saying, well, despite all of the roadside signs, I had people tell me they're up in Newport, they're down when you come across from Lake George, they're in Chittenden County. It was more than anything I've ever seen, and it made it really hard. But at the end of the day, it really came down to a discussion is, can we afford this? And do we have enough volume to constitute a direction towards quality? So I know that's hard to say, and people really would fight over those issues. As a perspective, and we did a lot of research, you know, over New York Times article from December 2024, not that long ago, over 500 hospitals have closed in a study from 2010 to 2022. So that's give or take 12 years. 500 hospitals have closed the birthing centers. So 2022. 2023, we had an additional 20, well, the number got up to about 570 to 600. It's amazing how the data is not always kept. In 24, there was another 37, and in 23, there was a similar number around 32. But that's a lot. That's, you know, give or take 600 hospitals closing the birthing centers. And the reason why they would do this is because of mainly financial distress. That was the primary driver. In any healthcare system, sort of known, I've discerned this, but we see it, that if you're in distress, what services can you really not afford because of not even getting labor? And the three services that are most difficult are inpatient psychiatry, which we saw UVM close at CVH, understandably. Really hard to get inpatient psychiatric. Even worse if it's a lockdown unit versus inpatient regular unit. The other is nursing homes. And nursing homes, we just had Genesis make that announcement 2 weeks ago, 3 weeks ago, that Genesis was closing up, went bankrupt, a whole bunch of nursing homes. We know the stress of running a nursing home. Very difficult to get staff, a lot of needs, and yet all of us cry for this situation, much like the births, because it's our elderly, it's our frail elderly. And the third of the three is birthing centers. So just wanted to share that and give it that perspective. Now, the amount of communications, you know, there was a lot, you know, close to 400. Most people just being against even deciding it. Television, articles, opinions, newsletters. We continue to get stuff on Reddit. I mean, people were really very upset with us even thinking about it. And some of their comments were very hurtful. And that's really hard for all of us. We are trying to do the best job we can on a number of fronts. Healthcare is really complicated, but I do believe the outside perspective of somebody saying, where can you find opportunity for improvement? Coordinating together, getting rid of waste. How can you become more efficient? We are trying to squeeze everything possible. And, but some of the comments were just really very biting. And here's a few more comments. Some of the stuff is pretty wild, like Copley's projected to make 10 million next year. If you remember the first chart, Jeff will show, we haven't made 10 million if you add up 10 years of operating margin. I love the third bullet point, lucrative bonuses for board members. That's been mentioned a couple times. Well, the board, you ought to look at what they're getting paid. The board members, they give more than any other volunteer. And we've got, hundreds, 200 volunteers. Board members give their time tremendously. Kathy, appreciate you being here. They give their heart and soul and their emotion, and they love this community. And some of them have been here for generations. And so it's when you're picking on the board members and saying they don't really care, again, it's kind of hard. So I just wanted to share that with you. My concern with all of this is, are we strong enough to actually do these things? Because the road ahead is not going to look easier and brighter when it comes to all of us being asked to think differently, less egos, share services, try to help each other out. We study this, and we did come to the conclusion that we probably should do this, we need to do this, and we need to make sure that we're saving the greater hospital. We did talk to our partners, they've been very helpful. Sort of the UVM network has been very helpful. Sean Tester at Northeastern Vermont, Tom Frank, as well as Peter Wright up in sort of the North Country. They've been all very helpful with Sunny Even, and some of them are looking at bringing staff to help with the prenatal care and postnatal care. And, you could say, well, why wouldn't somebody else close? We had the lowest volumes. And yet I think we still need to coordinate on not only births, but other services. And we're going to have to continue to go down this road. But everybody's been supportive. I know members of the Hospital Association, everybody has said, wow, Joe, we really know that you're going through a tough time. Good job. We're with you. But it's not been easy. So thanks for listening on that. That was therapeutic for me. I needed it. Service line support as opposed to just cutting back. We've spent a lot of time this past year. Kathy has spent a lot of time as one in this room, working with Memorial Health Partners, our FQHC, supporting them in 24 and in 25. We provided an emergency grant of about $150,000. We entered into a memorandum of understanding back in December of last year to think about how we could maybe become much more integrated. These are tough discussions too. These are not easy. We'd love to help out and be more of a team. And I think sometimes when we all start running out of money, all of a sudden the issues that you don't want to talk about, we need to talk about. So we have tried to help them. They transferred some of their lab work to us from New Jersey. We really appreciated that. That's been helpful. They had to close their Stowe clinic. It was really unfortunate, understandable though, and their diagnostic unit there, some of that has gone to us. And we purchased a very large MOB as opposed to an MOU, medical office building. Love the acronyms. We purchased that, which is across from the hospital, with some cash up front to help them out. That was part of an effort where they were working with AHS and a number of others to get help and relief because of changes in leadership and just having a hard time being primary care. The other big service line support across all surgical services is for us to add this fourth OR, which is a direct response to increased demand for services. We've got a growing patient need. It improves our finances, keeps care local. And our waiting list on surgery is very significant. Now, the funny thing about this is back in 2016, I think the CON probably started in 2014. It took a long time to finally have Copley rebuild their surgery center. But Copley did have, they had 2 procedure rooms and they had 3 ORs. And Copley, through that process, wanted to add a procedure room and an OR. And in the end of the process, and I'm not blaming the Green Mountain Care Board or the Public Oversight Committee, it's just a difficult process. They didn't get a procedure room and they didn't even get an OR. They just got to replace their existing. So we've always been short, volume-wise, both a procedure room and OR. So this is actually an OR that we had a demand for going way back. So,
And we should say that OR is not just for orthopedics.
oh,
It is
no,
to
no, no.
increase our women's care who are surgically, the GYN services have increased and we need that time in the OR. So
Right. And we have a lot of general surgery
Correct.
cases. Sometimes we use it for pain. We used it for urology. There's a lot of other folks that use it. It's not entirely. Thank you for saying that, Kathy. I know sometimes people
hear
think that, like we only care about orthopedics. That is not
true.
That's not true. Yeah, we care about as much as we can in terms of what we can. Other areas, oncology and infusion, that was renovated, and we saw a lot of this, and we're still seeing this in our FY25 performance. We moved to a larger renovated space, which was really important. That service is well loved. That service engenders a lot of commitment and appreciation from all the patients. The staff do a fantastic job. The laboratory services we talked about, that was a switch from Quest, a for-profit, out-of-state lab company. Just saying it like that. I wish
Hi,
none of the
Colleen
work would go.
Citrandich here. How are you?
I'm doing
Good.
okay.
Is Summer Birch around? Does she have a moment?
That's somebody who
Oh.
doesn't. have mute on.
Maybe somebody needs mute on.
Yeah, I think we got it.
Okay, thanks. So laboratory services, again, I'm a little concerned that any lab volume goes out of state to a for-profit. Radiology mammography, we've got a very significant upgraded mammogram machine that does contrast enhanced mammography for not screening, for diagnostic, and in fact, will replace potentially the need for us getting a breast coil for the MRI. It's really new technology. Dartmouth doesn't even have this yet. And they're helping us put this into practice. So it's much better and easier, and we have access. So wanted to just point that out. And then general surgery, we lost a surgeon that did colonoscopies. He was here for like 30 years. Dr. Silverstein, Joel Silverstein, he came down with some significant medical issues, but we got a replacement from Dr. Lou May. Again, as this story can sometimes happen, he moved into the area and somebody said, you ought to talk to the hospital. He's very skilled. He's been doing colonoscopies, upper and lowers his whole life. He came from a practice with 8 to 9 specific GI folks. So we're really happy about that. So we are open for those opportunities. I want to talk about the collaborative next. We call it the collaborative as opposed to spelling it out. It is the New England Collaborative Health Network. The genesis for some of this goes back to COVID-19. You know, COVID-19 was bad, horrible, difficult, expensive, challenging, whole bunch of negative comments. However, going back to my other comment about where we are, the lack of money and the need for us to say, help each other. So we worked with the home health agency that is here, the mental health designated agency, the nursing home, 2 primary care large practices in the hospital. And we talked about policies. Do you have masks? What about gloves? What do you do with people that are sick? We did a great job, and it felt really great that we were stressed and came together as a small team. And so that was our sort of local integration. We're still working on it. And the collaborative is a larger integration model. When this collaborative first started, in the bottom left, it says Vermont Collaborative. And we talked about keeping care local. These were brainstorming exercises with a whole bunch of folks. Sorry about that. Reducing costs, workforce, other. We also went through other exercises that said we need new programs, shared administrative functions, long-term partnerships, and then we even came up with a third model. We've talked about this a lot, like what could we do together to improve quality and really cut costs, actually make it easier for the patient, better access. So these are the things that we're working on, and it's pretty exciting. We do have partners that we've worked on the bottom right. That is Ovation Healthcare as being a group purchasing venue that's helped us save a lot of money. We also have the Richards Group out of Brattleboro. They do a great job with benefits. Hub does a lot of insurance. And the model is basically saying if you're independent and you're a CAH or a PPS hospital, we've never thought that a tertiary care center would want to join. That would be kind of funny. And you're rural, then this is the intent of this. This is sort of rural America. We've got that Maine, New Hampshire, Vermont, upper state New York. We've got it throughout the country. And it's both a macro and a micro integration model. I want to share that with you. So in Vermont, we do have two major networks. You know, we got Vermont with a big footprint in upstate New York, and we've got Dartmouth with a massive footprint going into Maine, New Hampshire, even, you know, we've got 2 hospitals listed. But the collaborative is everybody in between. It's all the hospitals in between that want to stay independent, that want to try to continue to be more cost effective and support each other. So the founding hospitals were the 3, St. Albans, Morrisville, and Brattleboro. And then we actually had Adirondack Medical Center join us. We had Cottage join us. We've had a couple of other hospitals, Gifford and Grace, join us. And we actually have community care partners I'm going to talk about up in Franklin and Lamoille and Caledonia that have joined us. So it's not just about hospitals. It's about more of a continuum of care locally. Here's a great chart of our history. It takes a long time to develop the trust and to work together and say, what can we do so it's win-win, or how can I help you out? It's really been a pretty successful process. Here is a map of our particular hospital, and the collaborative has hospitals and is inviting many other providers to the table. So we've got Copley, and that's sort of our service area. But these are all the other services that we talked about from COVID. Most of them around the hospital. They've got a footprint near the hospital, and out of those, Copley has joined, Lamoille Home Health Hospice has joined, Kathy's shop, Lamoille Health Partners, is on the verge of joining. I just heard that. Up in Caledonia, the FQHC has joined us. So we're really trying to develop a micro collaborative so that we're really sharing, because we have the same staff and we're taking care of the same patients for the most part. The patients in our communities cycle through our communities. So if you see them in the ER and they get discharged to home health or from surgery or to mental health services, they're all our same patients. And we think there's a lot of opportunity to save as we work together, not just being part of a large network, whether it's Dartmouth or UVM, but maybe sort of a community-focused network. So there's the issues on the right that we deal with, whether it's the micro or macro integration model. And for Copley, those are the folks down below that I mentioned that we're working on to say, would you like to join? We can save you some money. Here's some of the cost savings on the right. Oops, sorry about that. So year 1, we've saved 6.5 million, and given who we are and our size, that's great, 750,000. Average community partner has saved 315,000. And so on the left-hand side, 7 hospitals, 3 FQHCs, 2 home health hospice agencies, 1 long-term care. So we're doing well, and we've got leadership councils, and it feels like a grassroots. We're a strong B team. Let's call us the B team. That's okay. We're working harder. We don't pretend to be the A team, but we'll work twice as hard as being the B team, save money and catch up. I don't know.
It's
Kathy?
working.
Yeah,
It's definitely working. My agency's definitely saving money,
yeah,
working together.
yeah. And I think the bottom line is we can talk about a lot of theory, but people like Kathy and other CEOs, administrators, they understand, they say, show me actual money. And we are doing that too.
Yes.
Which is great. So that's July 24. A year later, we've added all those. Feels kind of nice. It's great. So just wanted to end by saying healthcare reform has been going on for a long time. We did have Act 167, went to the Green Mountain Care Board. You folks, contracted all the Wyman report. That job was basically to assess the system for healthcare reform. That got passed over to AHS for implementing. And I know we've talked about using RHRC or maybe Blueprint or others. And our team is really to say, how can we help? So if there's some way in which we could help facilitate those improvements, changes, that would be great. And so I wanted to show you that slide. Jeff's going to go over some benchmark exemptions, some dollar issues that are quite important. Thank you.
So There was three budget criteria for reporting the FY 2026 budgets. We're going to talk about the exemptions that we're requesting. Again, an exemption is budget 25 to budget 26. And so the first one that I'd like to talk about is the local FQHC that announced that it was in financial distress. You know, as Joe has communicated, we reached out to them to give them a hand whenever we could. Due to that, they discontinued the use of their Quest Lab services. They did close their office in Stowe, so they needed to send over the radiology exams that they used to do. And so with that, Copley needed to assume, you know, the lab and radiology duties. We added FTEs in actual 2025 and non-salary expenses, and we've actually assumed the billing for those services. So that's why that area has a projected 2025 impact, because that's when it started. Moving into the 2026 budget, we did assume those services would continue. The other exemption is our fourth OR. That will be opening as of 01/2026. Again, you know, Oliver Wyman, you know, kind of gave an edict. You either grow or you don't. And actually indicated we should try to become that regional referral center. The other issues is this is a direct response for demand. It will improve our financial stability. It will keep our care local. It improves the patient experience because we're going to be relieving a backlog that we have. And it also, will help us to relieve the pressure due to UVM not being able to move on their ASC expansion. But the good thing is we can do that, expansion at lower rates, which will help save Vermonters as well as the insurance companies overall. This one has, okay. A little bit of graphics in there. So overall, our net revenue growth guidance was 3.5. Without those exemptions, we're at 12.8. With the exemptions, we're at negative 3.7. I'm going to jump down to the number 3. That is our operating expense growth. The guidance in the 2026 budget was an increase of 3%. Without the exemptions, we were at 12.5. With the exemptions, we're well under that at 0.8. Last thing I'm going to talk about and get into more detail, though, is our guidance on the commercial rate growth. That guidance was set at 3, and we are requesting a charge master increase of 4.61.
And before Jeff clicks on the next one, I just want to say we're small. We're 3%. So some of these numbers, when you say, oh, wow, without exemptions, it's 12.8%. We can have one provider leave or somebody add, or even getting the work from Quest is actually a big deal for us just because we're small. So it makes those numbers sort of look dramatic. But in reference to who we are, we do have dramatic swings because we're just small. So, we have people take vacation and not fill their OR schedules in August. And we notice it. Like we have to talk about individuals and where they went on holiday to figure out how come our revenue is off. That's all. Right.
So next is jumping into our charge master, our rate increase. Put this back up there to say that we are an organization that has seen losses over the years. We need to achieve that reasonable margin so that we can continue to operate in the healthcare reform environment. We need to be able to withstand unexpected downturns. Just like Joe said, we lose, Dr. Doyle, we lose that service. We have an incredibly old building and aging infrastructure, and we need to be able to offer financial stability for our employers and our community. And so overall, this was a comparison of us to our critical access peers. Again, it's the operating margin. Jumping into days cash. Overall, 5-year average for Copley. Our days cash on hand is not where it needs to be. It's at 79. We're the second lowest to all other critical access hospitals. We'll need several years of margins to be able to, rebuild the reserves to get to where we need to be. And how do we do this? We need to be reimbursed like others. We need to control our costs, and that's why the collaborative is so important. And we need to capitalize on collecting everything that we build. So, with the announcement of our birthing, center closure, we have been getting a lot of attention in the media. We've been seeing these and reading these, but when you read into them, it's not just us saying that Copley is an affordable organization or that its charges and rates are, below what everybody else is. Some of the comments, we remain one of the most affordable hospitals. An X-ray of the foot is $400 more at UVM versus Copley, and quite a bit more affordable for services on the commercial side. The next data is data that was presented last year. It was actually using the RAND data from 2020 to 2022. And overall, this shows Copley in that data was the lowest compared to the rest of Vermont hospitals. Oh, no.
So Jeff wanted me to jump in. So just sort of feedback. One thing that's sort of frustrating, I know you don't want a list of my suggested improvements for the board, but I'm going to do it. Some of this data is good, but we stop collecting it or we stop updating it. So I said to Jeff, why would we use this? And where's the more recent data? And I know there's a lag time with RAND as well as others. Sometimes, like our cost report data, the most recent fully complete is 23, correct? 24. Yeah, but some data we used was 23 when we did the study. Correct. So I just want to sort of throw that out, that I think it's really helpful with some of these to stay committed with the data and make sure that each year we sort of look at that when it comes to cost of care or administrative expenses. I think Jeff's going to go through a few of these, but they're not as current as I would like them to be, but that's all.
So this is a slide that, we've been, constantly updating. We realize and appreciate that Copley for the last 5 years has been getting above average rate increases. And that is, really, appreciated. But in 2022, looking at this data, none of the Copley rates were above the state average. And looking at all the other hospitals that were reporting the Act 53 data, only 14% of the hospitals, Copley had rates that were higher than theirs. Moving now to 2025, we see that we're doing much better. 2 of our charges using the same data are above the state average. And we've moved the needle in regards to other hospitals where now we got 20 to 25% of Copley charges are a little bit slightly higher than other hospitals.
Oh, as part of that, so as part of all of this, we had the disclosure of and transparency of pricing. But unfortunately, I think the Hospital Association nationally and others did it in a way that made it really difficult for patients to see it. The requirement was machine readable format, which I thought was a very insincere requirement. It made it difficult for people to actually say, I wonder how much it's going to be to get a chest x-ray, a plain film chest x-ray, looking for pneumonia or whatever the service is. So we've been sharing with you, as Jeff has previously shown, all the hospitals, the prices, and this is only for 4 categories. There's literally thousands. But I think we really collectively need to do a better job of this. But when you look at the price disparities, I think going towards reference-based pricing, I'm probably one of the only hospitals that think it's probably a good idea, because we've got discrepancies of not only 100% twice as expensive, it could be 400% more expensive, 600% more expensive, and it really is difficult. There's a lot of buttons and dials and levers in healthcare, And every time we pull one or turn one or flip a switch, it's got an implication. But this is so fundamental for people when they go to get care to say, oh my gosh, so your sister went to an ED and, I went to an ED 2 weeks ago. And what was the price difference between the two hospitals? So we're a big proponent of saying that particular variable should be locked down. So anything we can do to sort of help in that reference-based pricing model, I think would help the fairness of all Vermonters. So just wanted to go over that slide with you.
Looking at our cost of care. Again, this is a slide from last year, which demonstrated that Copley's cost per adjusted discharge was $8,587. Overall, that was the third lowest in the state of Vermont. Taking a look at all the CAHs in Vermont, that goes up to 10,179, and the Vermont overall average goes up to 12,430. National critical access hospitals jumps to 14,000, and all national hospitals goes to 11,987. So, honestly, Copley is able to offer quality care at low cost. This was also a slide from last year. It took and looked at the admin salaries to clinical salaries. And overall, this was a view of just the critical access hospitals, but does demonstrate that Copley's the second lowest as compared to the other critical access hospitals. The last slide that I have is new data that we have received on the cost of care, and it's the total admin cost to the total cost from the 2023 cost report. Why I really like this data is this looks at the cost after all the allocations are done. When you actually then rank order these results, it comes in that Copley is the second lowest to all Vermont hospitals with cost of care.
And I just want to go back to this because the giant box on the right is all the details to make sure that the data is correct in comparison. It's so easy to look at data and say, well, as Jeff said, this is after full allocation, so it's more fair and appropriate and reflective. But again, I would love us to stay focused on some of these as a state so that we're really looking at them and understanding them and moving forward. So lastly, I'm going to turn it over to Jody Legacy. Very happy for her to talk about quality. She has rejoined the organization. She went and got her family nurse practitioner degree. She's been practicing in primary care clinics. She used to be an infection. Jody, I'm so happy that she's back. She brings a lot of enthusiasm. So I'm going to turn it over to her, and I'm sure it'll be entertaining and more fun.
Okay.
Click on the right. Thanks.
Thank you, everybody. It's so good to be here. And I just want to thank the board for allowing me to speak to talk about quality. And thank you to everybody who is listening in. It's really important that we're all listening to the changes that are happening. One of the things I think that is really evident across the board is the fact that the roadmap to our healthcare is changing in the state of Vermont. And I think we're all aware that it needs to change. We're in a little bit of a crisis. And so as the state of Vermont finds itself at this crossroad in its healthcare delivery, we are asked to make tremendously difficult decisions. And as a state, we are looking at ways to improve our systems and finding approaches to allow us to be more effective and efficient. And this is allowing us to provide affordable care to not only our patients, our friends, our families, our communities. This is meaningful things that we're talking about. And this is why I love quality and why I love Copley. So at Copley, we have been striving for this as long as I've worked at Copley, which I've been here for 8 years, because we've always strived to meet the needs of our patients in our community. And as we have learned, we're serving other communities as well. And in this transformation, we've had to make significant changes as an organization in our operations, in our staffing. And most recently, we made a very big decision to close our birthing center, our loved birthing center. And that was a truly difficult decision for everybody who had to make that decision. I think that's been evident in the discussions previous to mine. However, there are challenges and great opportunities ahead that are going to allow us to work together to deliver care to our Vermonters. And that is why we're here. And we want to promote access to care for not only critical access hospitals and our tertiary hospitals, but also thinking about our primary care, our women's health services, surgical services, mental health services, emergency care services, and inpatient care services. And one of the things that I think is evident is that Copley is driving the way by making those changes. We are working hard to keep our doors open and keeping healthcare in rural Vermont. And that is so important, not only in Vermont, but across the nation. And I have to personally say that to many of us, Copley is our home. I call Copley home. Next slide is. So as the newest director of quality here, I come with a background, and Joe gave a little bit about my background. I've worked in environmental services. I've been a unit clerk. I've done secretarial work within a healthcare organization. I was a bedside nurse for 15 years. I have been a nurse practitioner, and I worked in primary care serving Central Vermont for many years. And then I'm also an inpatient hospitalist here at Copley. I studied population health and got a master's degree in public health and global health because I thought it was important. If I was going to work in healthcare, I needed to understand how to operate at a population level. And I think as the director of quality, this gives me a unique perspective to help build the bridge, to help provide and can bring together our community partners to build healthcare for our community. One of the things I have heard and learned is that Copley has been known, and I think we're very much prideful of the level of care that we give to our patients. It's the highest level of care that we could give, and it's high valued. And as we're noticing, it's very low cost. And although we are in a business to serve our community, we have to be sustainable. And I think that's important. So one of the things I think as quality director is we recognize that change is inevitable. It's the only constant that we face in our lives, right? Change. And I don't think I need to educate anybody in this room or anyone listening that change starts with data. We need to have the data to make good change and good choices. And so for me, I want to put us on a reset. Quality department is resetting. We're building up. I want to start from the ground up because if we continue to build on data or information that maybe not have the structural integrity that it needs, what we do is build onto something that's unstable. And then it fractures and then it crumbles. So my goal is to build meaningful data. I want meaningful data. And I want that to be starting by restructuring how we move that through. I want our data to be understandable and approachable to all people of all backgrounds. In order for people to make informed choices and informed care choices, they need to understand that choice. I want the data to be transparent because I think we do exceptional work here at Copley. I practice medicine here. I'm a provider here, and I see it from how we practice in the emergency department and our care that we give our patients on the inpatient unit. When I'm rounding on those patients, there's love and care behind our care. And I want everyone to know that outside of just stating it. I want the data to be evident of that. So I want our patients to make informed decisions. I want our providers to know how they're doing and how we can improve. But I also want our governance to continually have the data they need to make those strategic planning and decisions that are really important as we're learning. And I think that is the beautiful thing about quality and why I'm here. I wanted to discuss the hospital compare report card. I think this is, everyone's talking about it. I always get asked about it. And so I thought I'd bring it to the table. The July data just was released and we went from 2 stars to 3 stars. And I'm okay with that. It does not mean that I set the bar low. It just means that we have made progress because I have high expectations across the board of how we deliver care in the organization. However, progress means we're moving forward. We have looked how we have done over the last 4 years where we went from a 5-star to a 4-star down to a 2-star. And now we're making the changes. Now we're moving forward. I am confident that we'll continue to make progress. And as my son is in sports, perfection is not something we strive for. Progress is what we strive for. We want to move forward. We're driving ahead, going ahead forward. And that is something that I think is important. The other thing that I wanted to point out on this slide that I think is really important is the patient survey ratings. They're 5 stars. I say this only because As I looked over the data over the last 5 years, we get 5 stars because our patients like the care that they get at Copley. It's a home feel. There's just a little bit different level of care when it's your home community hospital. And I think that's really evident in rural healthcare as well. So not only do we look at the hospital compare, and I respect that, but there's so many other ways that we get data at Copley and the way I'm building our data. HCAHPS is part of the survey of the CMS. We look at patient satisfaction scores, for those who don't know what that is and listening in. Our patient satisfaction scores are what we send to all our patients that are discharged, because we want to know how they are being treated as patients. Are they feeling they are prepared to be discharged? Are our doctors, our nurses, our staff taking care of them in the right way? And we are getting 5 stars. I want to improve how many people respond. Their numbers have trended down a little bit, so I think we have some room for improvement. NSQIP is our national surgical quality improvement program that we participate in. This is elective. We do report surgical outcomes and surgical site infections to our mandated CMS and HSN. However, we believe in safety, we believe in quality, so we electively participate in this program, and we are by far below the benchmark because we do care about safety and we do care about how we do in our surgical services across the board. The PROMS, I think, is a really important patient measure that I think is so valuable because it is the patient-reported outcome measures, and it is the survey we give to all of our total joints for our hips, knees, and shoulders. It allows them to report how they feel before their surgery, immediately after their surgery, and up to 12 months to 2 years after their surgery. And what I have learned, and most importantly, is that we are improving the quality of life of people. And I don't think there's any more meaningful measure than finding out that we're improving the quality of life of our patients, because I think that's why we are here, to improve the quality of life of our patients in Vermont. Our community health needs assessment, this is a wonderful, wonderful tool, and this allows us to build with our community partners and helping meet the needs of our Vermonters. And we participate in this, but we also use this to bridge what is needed to be bridged. So our last one noting that access to primary care. So we built programs to do that. Mental health services, we're building that. Recovery coaches, we're working on all these implementations of initiatives that need to happen. But of course, it takes time, it takes energy, it takes funds, and funding is so critical. Our event reporting system is a very wonderful tool that I love to utilize because it allows me to build quality improvement initiatives because it comes from our staff. This is not only just our providers or our PTs, it is our EABS, our facilities, it's our HIM. If there's a problem that is found, we report it and we take this seriously, as well as we listen to our grievances and patient complaints. We track them, we monitor them, we evaluate them. I didn't show a lot of data today for a purpose because I wanted to talk about what we're building. I'm talking about how we're building and moving forward. And I think one of the things that I just want to say is thank you to the board for allowing me to, one, talk about the quality and in my plan to move forward. But I also understand the complexity of what we have to face in front of us. And the road to healthcare is changing and it's challenging. And it's going to be a little uncomfortable as we change and evolve. And I think that that's one of the things that we're going to have to recognize is that change can make people feel uncertain, and that uncertainty can be so unsettling for people. So as we do evolve in our landscape of healthcare, I think we all have the same common hope, and that is to continue to provide care to our Vermonters in Vermont. Thank you.
Great. Any questions? We're all here to answer them and pitch in.
I'm sure there'll be a few. Why don't we start with Member Walsh?
All right, thank you, Chair, and good afternoon. Thanks for the presentation. Most of the NPR and operating expense growth in your budget is tied to the Memorial Health Partners and operating room, the exemptions that you've requested. I just want to make sure those are one-time exemptions. Is that correct? They'd be part of the budget's going.
Yeah, Jeff can jump in, but it's kind of funny, Tom. many years ago, they decided to send their work to New Jersey, to Quest. And that was really unfortunate. I know I made the comment, about trying to keep care local and keep money local. So I hope and pray that doesn't happen again. It'll be in the wrong direction. But yeah, the exemption should be at one time and then we're done. And we should be sitting there. The same with the OR. It's a one-time capital build, and then we're going to be serving a lot more people at a better price and a better rate. But yes, yeah, it's a one-time exemption. But thanks for asking. Yep.
Thank you. And would you be, this is part of the usual budget process, but specifically for these two exemptions, would you please report to us the volumes, the revenue and operating expenses for the two exemptions going forward for the next couple of years? And then how the revenue is aligned with your community need.
Yes.
Right.
Tom, can I interrupt?
Yeah.
Mr. Wood, do you have your screen on a share screen on the, I'm kind of getting a little ill looking at ourselves.
I'm not sure what.
It's just, yeah, there we go. That's better. Thank you. Getting seasick.
What were
Thanks.
you looking at? I don't know what you were looking at. What were you looking at?
Myself, and I was horrified.
Oh.
So,
I should have, technology's great when it works. So I didn't know that. Thanks.
yeah, you've got to look away, right? It's one of the hard things about this. Yeah. So what I'm trying to do with my questions, we think about these questions as fact finding, and I want to try to lay the groundwork for following facts with these exemptions and the work and the transformation that you're starting to do with the collaborative and the changing some of the service lines.
Yep.
So you've got some unique demographics, as almost every region in Vermont does. But I'd like to see how the changes in the service lines tie to the needs assessment, the community needs assessment, and that the revenue, the improvements that come are tied to those community needs. If that could be a focused part of the data that you provide to us in your presentation next year, that'd be great. And with the birthing center, I understand the difficulty of that decision. And similarly, I'm hoping that you would help us with fact finding in your community. If you could help us track that any increase or change in ED visits that has to do with obstetrics.
Yep.
Any difference in maternal or newborn outcomes.
Yep.
And any changes in prenatal or perinatal adherence. I'm interested to know if people leading up to the birth, after the birth, have trouble getting care because of having to travel.
Yep.
That type of data would help us so much, not just in your case, but with the other types of changes that will happen with transformation. So I appreciate your help with that. And I think I'm asking for those specifics from you, partially because you're so involved with the regionalization already with the collaborative. And similarly with the collaborative, the savings that come from that, I'm sure they're expected. I'm hopeful about that. but helping us quantify those.
Yeah, no, good questions.
Um, I don't want to bog us down with a lot of other. Yeah, I think you've asked, without the exemptions, you've asked for some large increases in prices, growth, operating expenses. I can be a lot more comfortable with that. You've been persuasive with your findings about your low prices. They've been going up. It would be reassuring to me to be able to tie changes to community need. So that's what I'll be looking for over the next few years.
Thanks. Yep.
Back to you, Chair. Thank you.
Thank you, Member Walsh. I have a couple of questions. I think I know the answer, but I just want to be clear for the record. So the changes in service lines, sleep medicine, birthing, aquatic therapy pool, and cataract, has the NPR related to those services been removed from the budget?
The answer is yes.
Okay, great, thank you. And then on the birthing, I appreciated you addressing that up front. I think it was important too, and I appreciate hearing the thoughts and perspectives and the challenges in connection with that decision. One of the points in the submission is that there's an annual loss about 15 to 30,000 per birth, and the costs are becoming greater. They can be managed. I understand that. My question was, how did you calculate the loss per birth? And I asked because a lot of different hospitals have different ways of calculating gains or losses on different service lines.
It was Jeff could jump in. I think it was the total loss divided by the number of births, but those things, the number of births has been changing a bit. So it comes down to, I think that I could be wrong. The number is between like $20,000 and $30,000. Depends upon what number of births you use. I mean, the past year alone, given the precipitous drop in volume, that number is wildly much higher, continues to be higher. I think we only have 2 more births scheduled for this month, and it's only the 13th. So yeah, so that's why there's a range there. It's not like one point in time calculation, but maybe that too. Oh, that's oh, okay.
So when you say total costs, you take the total, what are you referring? Does that include some administrative overhead that gets attributed to the service lines, or I just was not clear on that?
So it's the total loss that's just the calculated total loss divided by the number of births. And as Jeff showed in his chart, it includes administrative overhead. It includes the sort of usual and customary allocation process used in the Medicare cost report. Is that right?
Yeah.
Yeah. So there's no, and you can talk about not allocating things. So we spent a lot of time on a number of issues. And if you say certain services we're not going to allocate, then you run down a rabbit hole of saying, oh my gosh, so if we don't allocate appropriately overhead, then that becomes sort of an accounting game where you end up saddling other people with overhead. So we talked a lot about this, but the calculation is total loss divided by the births.
Okay, I think I understand.
Yeah.
On the diagnostic imaging that was rerouted from Quest to Copley, I didn't quite follow how that saved Lamoille Health Partners money.
Yeah, it wasn't from Quest. The diagnostic imaging was because they closed down. They had to make some very difficult decisions, like we all have. So they really had to look at their Stowe practice office, just the expenses, and they just couldn't afford it. So when in closing that, we're gracious and happy to accept and pitch in with the laboratory work. We actually help with some of their laboratory draws as well as they had a sort of a plain film X-ray of some sort in that office, and that was closed down, so that work ended up just coming to us, you know. So it saved them in the sense that they don't have expenses, but they lost some revenue on that too. So it's just, you know, we're happy to help them. We've been meeting with them. We met with them dozens and dozens of times, trying to pitch in, help out. What can we do? We've helped them in a variety of ways. Not all of them are listed.
Yeah,
So
understood. Yep. Okay. Then the slides that you had comparing your prices to other hospitals, you anonymized the other hospitals, and I was wondering why.
somebody else can probably answer that for me. It's a small state of Vermont, so we try not to highlight. I know, I don't know why other people wouldn't sort of look at that. I don't know if you guys have spent a bunch of time and money as the Green Mountain Care Board also doing those assessments. So I assume you've got the same data. There is some gaps that hospitals aren't reporting. So we just did it out of respect and not trying to point out, or, you know what I mean?
But isn't that a competitive advantage for you?
What would be a competitive advantage?
That
Sorry.
you have lower prices by a significant amount?
In the normal world, yes. And we're not in a normal world. I feel like healthcare is so at times twisted, if not a little bit perverted with the incentives. So yes, it should be. And I know years ago when one of the presidential mandates was health savings accounts and all that discussion, which I appreciated, we thought people would become price sensitive, but still a majority of people are price insensitive. And so it's kind of a weird place in which we would like the best quality delivered at the least expensive location and maintaining access, but the public somewhat responds. But I don't know if I put ads in the paper about our lower costs. I don't really know. You know, that's a good question. You would think that it would matter a lot. It is somewhat improved. I think the more attention it gets, I think with reference-based pricing, that'll be a huge change. But there's been such a divorce for decades with regards to our healthcare that was provided by commercial insurances, and you get it when you're in Medicare or in Medicaid and others, that make us, unfortunately, a little less sensitive to price. So I don't know if I'm answering that. I think
Well, yeah, I mean,
yeah.
one, we really value transparency. And so I think if you have data that highlights a very critical issue to Vermont, which is the pricing at various hospitals, I think it should be transparent, and I'd appreciate you making it transparent. And then second, I think as Vermonters become more aware of the affordability challenges we have as a state, I think they probably are more sensitive to the fact that your prices are a number of services significantly lower. And we would like to see you act as a competitor, and we would like to see others have to compete on your prices. So I think I would encourage you to be competitive, and especially in regards to, you know, some areas where you are offering really good services at a high quality. To that point, you mentioned the UVM Outpatient Surgery Center. I hope it gets built, frankly. We have a pricing cap on that I think makes it a good service for Vermont, but it may or may not. You have an orthopedics practice, you have outpatient surgery. Would you consider filling that void, or why are you trying to fill that void?
Why aren't we trying to fill that void?
Yeah, if UVM's is not going to be built and you can do it at a lower price with high quality, it's an opportunity to expand.
I love that suggestion. So I think it just takes time and effort and competency. I mean, everything we do, we try not to ever spend money inappropriately. Money's always an issue. So I think thoughtfully, we will be considering that and have talked a little bit about that. But we're, you know, in terms of projects, it's even hard to find contractors that are giving you a decent price with projects. But that is something that I think we'll consider certainly in the rewrite of the strategic plan coming up this year, which is due by the end of the year. So, yeah, I love that idea, but we're always trying to make sure that we make good decisions. I don't know if you want to add in,
I
Kathy.
think the fourth OR will help.
Fourth hour, yeah, that should help. Yes, yeah, that's a step, but maybe there's more. Yeah. Maybe
Yeah,
there's
you had
more.
interested party status in that outpatient surgery center hearing, and I know you listened in on some of those, and if there was representations of a significant need that may or may not be filled, and I hope it does get filled. But if you are a low cost and able to provide that service efficiently as a competitor, it's an opportunity, and I just want to flag that. My only other question is on your case mix index, which you provided. I apologize, I don't have, oh, it's page 21. And it's, what jumped out to me is it's really increased significantly for Blue Cross and MVP. Cigna is actually down. So from 2023, it was 0.88, and now for 26 budget, you have it at 1.2. Cigna was 0.88, now they're at 1.28. And even year over year, it's a really big increase. And I was wondering why, what's driving that?
So I would need to dig into the data and get back to you to see, is it a shifting of DRGs? What is causing that? I don't have that data in front of me to do that, but I can get back to you on that.
Okay, that's great. That's all I had. Thank you all very much for your presentation and your time and your work for your community. And I'll turn to member Merman.
Thanks so much. I just want to follow up with a few questions that Tom and Owen just asked. So I think Tom had asked if the exemptions for the laboratory and the OR were one time, meaning I think he was asking, will those be in this year's NPR base, but not next year's NPR base?
What's going to happen with those, because of the increased volume in both of them, both with the laboratory work we're taking over from Quest down in New Jersey, as well as the OR demand, which is a little bit related to Chairman Foster's question about surgery and being a low cost. Those become reset. So it's not expected at all next year that we're going to be looking at resetting to another level above that. That just becomes our new baseline for volume of laboratory services, charges, revenue, and it's a baseline for surgery, volume, revenue, and charges, if that makes sense.
Yeah, okay. So, go ahead.
Well, what I was going to say is in regards to the lab and radiology, that's a 100% because that's already started. It's in our actual 2025. It's being built in to our 2026. In regards to the fourth OR, that's starting January 1st of 2026. So next year there will be an additional 3 months that will need to be added to that.
Okay.
Yeah.
And so essentially the exemption you're asking is almost like a provider transfer. You're expanding a service and you're asking to get an NPR bump to basically absorb additional services delivered. Is that fair characterization?
Correct. Yes. Yeah.
Okay. So
go on. Sorry.
With OB labor and delivery, the women's the birthing center closing, do you have a negative of that? Insofar as is that $3 million that you were losing on that, does that come out as sort of like a negative provider transfer from the NPR base, or are you kind of continuing building the NPR base off of last year where that was included?
So that would be coming out of our base for 2026.
So that of 2026, but is it, when comparing 25 to 26, it's in the base of 25, the service is not provided in 26, so it's not in 26.
Correct.
So it looks like a net. So with nothing else changed, the NPR would be net down, but then there's other things changing.
Yep. Correct. Yeah.
Okay. Just wanted
We
to
had 1 month in 26 of OB services, but the revenue, for the most part, it would be 100% reduction of that NPR revenue. Yes.
One other thing on the L&D birthing center was that Chair Foster had asked you about the price per birth. You started talking a little bit about how there's very few births right now, so that this year is very low, so the price per birth becomes very high. Could you give the price per birth for last year? That can be a written follow-up.
Well, the price is the price. Are you talking the charge price? Are you talking about the cost per birth?
Sorry, the cost per birth.
Okay.
I apologize. Yep.
Yep.
The per birth loss, I think, is actually how you described it in the narrative. Okay. When you get this, if you were to get a charge master increase this year, would you distribute that charge master increase evenly across all charges, or do you select certain charges that you try to negotiate a higher charge master increase with your payers and others that are lower?
First and foremost, what we do with our charge master increases is we'll take a look at the supplies. And so we'll run the supplies through and we'll then adjust them, to a formulary to, based on what the costs to buy those supplies are. So we'll then understand, okay, how much of the charge master increase did we, utilize? How much do we have left? In regards to our professional charges, we do ensure that we set those at the fee schedules so that we don't lose anything with lesser of kind of contracted rates. And then the rest will be distributed to like our radiology lab and all those different services.
Okay. So have you successfully negotiated for any services that are relatively higher than other reimbursements for services at Copley so far? As do you negotiate up certain areas to try to generate better reimbursements in certain areas?
In certain areas, our core philosophy is we make sure that that the charges are going to the appropriate items. We look at the APCs, the Medicare APCs. We'll look at the Act 53 data. We'll make sure that that we have them priced and that they're priced, competitively. And after that's all said and done, we make sure that we come in at the charge master increase. Do we look at service lines? No, we don't actually put it through that. We don't have a cost accounting system that gives us the ability to do such kind of analysis.
I guess what I'm getting to is, do you use strategic pricing in adjusting your charge master in order to, are you familiar with the term strategic pricing?
Yeah, I mean, we do, when we look at again, I'm not sure that we're using strategic pricing. We are looking at our payers and which items, by payer. But first and foremost, we just try to ensure that as we plug in our rates throughout the item, master, that we're coming in at what we are approved for.
Okay. I'm trying to figure out your traveler FTEs. It looks, there was a discussion in the narrative about going from 21 to 27 FTEs, but in one of the charts it appeared there was a 100% reduction in traveler FTEs. What's the year-over-year change in sort of the percentage of traveler FTEs at Copley?
So right now we're running FTE wise with our travelers about 30. When we put in the 2026 budget, we actually assumed that that those would hopefully not be travelers in the budget. They would be actual FTEs. And we do then in the salaries and wages include an inflationary increase for the premium to have travelers. And so we're budgeting right now 27 for this upcoming is what that premium is based on.
Okay.
Is there a member?
Sorry.
Just wanted to ask, is there a chart or reference to the reduction? And is there a reference there we could look up to?
1 second. I meant to write down the page. There on page 9 of the narrative, the bottom chart, it looked like, I think you have contract staff nursing is 13, FTEs in 25, 18 other, and it goes to 0 in the 26 budget. Oh, okay. So that, if you would just submit a correction on that, that would be really helpful, just so we can track that. So one other question is the Copley Health Systems Incorporated, the parent organization of Copley Hospital. Does Copley Health Systems Incorporated have any assets other than the hospital?
Yeah, so we have our investments live in Copley Health Systems for the most part.
Are there additional investments in Copley Health Systems that are not reflected in your days cash on hand?
Yeah, the investments are not reflected in our days cash on hand.
So Copley Health System has a 40-unit independent living elderly housing project in downtown Stowe. Used to be a joint venture with UVM many years ago. We used to have the terraced low-income housing part of HUD. That is, we ended up selling that. We have a health center building asset, correct?
Its own organization.
Yeah, its own organization. So for the most part, it's kind of dormant-ish, but the biggest part of it is the 40-unit independent living in Stowe called the Woodlands. Yep. And it used to be more complicated. We used to have a primary care. We discharged that in 2004, which was retrospect an unfortunate decision. We used to have the nursing home, the manor, that's been discharged. So Copley used to have a much larger constellation under that construct, but over the past couple of decades, it's been kind of peeled back as a reference point. You know,
that's helpful. Are there any cash or cash equivalents at the Health Systems Incorporated level?
Site investments is the cash.
oh yeah.
It's just the investments that they have.
And those investments are the facility of the independent living facility, or are there other investments?
Just the investments live in CHSI, Copley Health Systems.
Yeah.
Okay.
I think you're bringing up a good point about when you look at, I know there's discrepancies when it comes to hospitals, assets, days cash on hand, how much sits within the hospital, or it's allocated, or it's specific to the hospital or the parent. A really good question about understanding that and unraveling that to say, okay, what is that? You know what I mean? It's a great
So
question.
help me understand. I guess I'm asking you to help me understand that. Are there additional assets at the parent company that are not at the hospital, that aren't reflected in your budget submission here?
Well, Jeff can correct me, but they sit in the parent, but they're the parents, but I'm pretty sure they're the parents.
Yeah, the parents.
Right, they're the parents, but the parent has 2.5 children, and one of them, the biggest one by far, is the hospital. So, you know what I mean? To divide those assets and say, which of those are the Woodlands Health Center building or the terrace? Am I missing anybody? Yeah, it's a really good question. I don't know, Jeff, are they clearly divided as to which ones are the hospital, health center building, Woodlands?
They are not.
They're not.
Okay.
Which is usually customary, correct?
Yes.
Yes. So that's
Right.
a good question. I think it's usual and customary. They're not, and that's something to talk about. Yep.
Okay.
Good.
Just shift tracks here. You talked about Center of Excellence for Orthopedics at Copley Hospital, Oliver Wyman, all of that. Does Copley accept inpatient transfers to orthopedic care from other hospitals as a referral center?
Do we accept transfers from other hospitals?
Inpatient transfers for orthopedic related.
I think we do sometimes. We had a call just the other day, a couple of weeks ago, from somebody. There was a patient, and they said we can't get the patient into anywhere. Couldn't get him into UVM. Couldn't get him into Dartmouth. It turns out they asked us because of our orthopedic expertise, and it ended up becoming a blood-related problem. We just don't have a robust blood bank to do the type of very complicated crushed socket of a hip procedure to repair. I know we do get transfers down from North Country. We sometimes get transfers from other hospitals to say, could you take care of this patient? To say that we've got a permanent relationship of referrals that would come from a different hospital around orthopedics, we sort of talk through that because that does stress out our orthopedic team in terms of the amount of call they have and who they take care of and how much is emergent. It's a good question. Like we try to anytime we can, of course, but we don't have those formal relationships.
So when you think about the concept of a center of excellence for orthopedic care, are you thinking primary outpatient, or are you thinking of outpatient and inpatient?
Well, I think we're already there, more so than I've seen in other small hospitals on the outpatient side, but I guess on the inpatient side, that would be true too. I mean, we can do quite a bit more than most any hospital. So in our service area, now that's a discussion about whether it's the county or the county plus a few other if you had an inpatient need for some complicated orthopedic surgery and we can do it, we'd do it.
Really, I'm just thinking, a hip fracture patient where you don't have the size of the group that you have, that there's not weekend coverage, or maybe their one orthopedist is out of town. Can you accept the transfer on those inpatient?
Right. Yeah.
And it sounds like yes, no, maybe, depends.
Yeah, we do that. I mean, we haven't made the commitment that we'll take, and again, there's some stuff that if you came out of another hospital and they said, well, you're close by, would like to send it to you. Some stuff we just can't do, like that example of not having a sufficient blood bank. So, are we the go-to first spot to accept those transfers? We haven't had those agreements lined up. If we did, we'd have to probably hire more staff, which is not bad. It's okay. We just have to change expectations to say, okay, there are other hospitals that now we are the designated site, and it's not a matter of like your decision. It's like we have to figure out how to do that. I hope that answers it. I'm sorry, it's not super clear.
All right. With regards to the collaborative, does Copley pay dues to the collaborative?
Yes, we do.
And then does anybody do any of the board members of the collaborative or executives of Copley receive compensation back from the collaborative?
Individuals?
Yeah.
Oh, no.
Okay.
No. So the dues, that's a great question. So the dues are significantly less than the dues you would pay to be part of a different group purchasing arrangement. So the dues are, the savings on the dues are pretty dramatic. And we actually have an administrative share that comes back based upon the purchases. So we actually get rebates, and those get distributed to the members, and they can be used to reduce the dues. So yeah, we have dues, but they are much less. But they don't go to individuals. No, there's no. We have one employee.
All right, that's all I have.
Yeah, good question.
Thank you, everybody.
And we'll get back to you on some of that stuff. And the strategic pricing question, I think it's a great, I don't know how the board could audit that or get a better understanding, or maybe give each hospital, 25 or 50 charge code items and say, hey, what did you do? And what was the thought of the percentage increase in these 25 to 50 charge code items to better understand that strategic pricing methodology? I think it's a good question.
Thanks.
Member Teachout.
Thank you. Good afternoon. I'll start with a basic question. Where is the fourth operating room that you are opening located? Is it in Morrisville or is it in your Waterbury office?
It's in Morrisville.
Okay.
So it's a fit. Yep. It's in Morrisville.
Okay. Thank you. I just didn't know where that was. Next, I wanted to jump to on page 10 of your narrative. You had a budget 25 to budget 26 percent change in different items. So you say due to Lamoille Health Partners financial crisis, 6%, due to fourth operating room, 11%. What are you talking about here that went up and down? Which part of your budget? The NPR, the commercial revenue? I'm just not clear on what this refers to exactly.
Okay, so
Or utilization, I just wasn't sure.
one second.
You know, I think I understand when I read it and then I
Yeah.
have questions.
Based on utilization increase.
So the difference between the 25 and 26 budget utilization is up 6% due to Lamoille Health Partners financial crisis.
Yes.
Okay, thank you. Another question, because I do remember when Lamoille Health Partners shifted their lab work away from Copley out of state to Quest. I think one of the things they cited was a lower cost for patients. I completely agree that keeping services in state makes a lot of sense unless there's a massive cost differential that harms patients. How does your prices for lab work compare to Quest?
Great question. We went through this in detail with them at the time. We did a price comparison with everything that Quest had listed on their public disclosure, which is a lot, and we were at matching or below. There was no price difference there, and it was a complicated conversation. That's a really good question. Yeah, were you guys more expensive? And the answer is no, we were not. And I can send you that if you want it.
If it's current, if it's not current, I know the prices change all the time. My next follow-up with that is, does Copley send some of its lab work to UVMMC?
Yes. So we every hospital does what they can do, and we've got some new laboratory equipment which gives us some more capabilities. But you don't do what if you can add on tests with little to no expenses, you'll do that. But at some point you say, we can't do that, we don't do it. So we do send work to UVM, and UVM sends work to Mayo, and UVM sends work to others. So I think we typically actually go through UVM to even get to Mayo. I'm pretty sure that there is like this trail. So we do everything we can do. UVM takes all the other stuff. We're happy, super thankful. And then UVM sends stuff out, or we directly send stuff out. I don't know if you know.
We do. We send directly to Mayo, but we also send like some of our pathologies to UVM on courier.
Yep.
Do you send it to Dartmouth too?
I
Or
don't
is it
know.
just-
No, that's
Okay.
just because we have an agreement with the pathology reading with UVM.
Yeah.
Okay. So now I'm back to my question that I had earlier on how is that billed to the patient? If you send your lab work up to UVM, does the patient get billed by Copley or by UVM for whatever is needed there?
The patient will get billed by UVM for that.
Okay. And that's how it worked also when Lamoille Health Partners was using Quest. Quest was billing the patient or the insurance company directly.
Yes.
Okay.
Yep. And just as, if I can, in regards to once those services, were transitioned back from Quest to Copley, one of the things that we definitely wanted to make sure is we asked Lamoille if there is any issues with pricing to let us know ASAP. This has been going on for well over 6 months, and we have not heard any issues.
Okay. Great. So different topic. Under on the same page 10, you have rate changes by payer, and you say Copley is requesting a weighted rate increase of 4.6%. What do you mean by weighted in that context?
So weighted goes back to, again, what we'll first and foremost do is we'll take a look at our costs for our supplies as well as for our pharmaceuticals. And we make sure that we're covering the cost of that. And then we'll, take then the next step is to look at the fee schedules, make sure none of our rates are below those fee schedules. And then whatever is left over, we'll then, evenly spread that so that, we don't have a Blue Cross, so that we don't have an MVP coming back saying, hey, you were only supposed to do a 4.2 and you're coming in at 4.4 or 4.5.
Okay. Okay, great. So what you're saying there is that the end result will be 4.6% increase, but there could be ups and downs amongst all the charges that are not 4.6%.
Absolutely.
Okay, thank you. Just wanted the clarification there. And then it's both on the next page and in other places. You are budgeting an overall operating margin of 2.69% or 3.5 million for 26. How would you say that fits with your sort of financial philosophy for balancing your budget and being a stable organization in the future?
That's a good question. When you talk about the reasonable, fair financial sustainability of an organization, you could say, how many days cash on hand do you need? What seems reasonable? And I think those discussions have taken place where people say, I think as a lower limit, what's the lower limit on fair and reasonable cash?
The lower limit is 120.
125 days. And then there's the discussion about, well, what's a reasonable upper limit on cash? What is it?
It's about 150.
150 or two. So you sort of look at those. So when it comes to prices, it's almost like reference-based pricing. So what is a fair and reasonable operating margin for an organization to pay for capital, programs, equipment, infrastructure? So I think I've discerned this many years ago. You can certainly work with bondholders, people on Wall Street that sort of look at what is fair and reasonable. As a nonprofit, I'm not talking about a for-profit, which would do anything they could. I think that range of numbers, which I would advocate that we should sort of set as a goal, should be somewhere between 2 to 3%, some 2.5 to 3.5%. Say 2 to 3%. So if people are consistently below 2%, you're looking at problematic organizations that probably you should say, well, you guys are well below 2%. But if you're 5, 6, 7%, I think the question should be, you should be cutting your prices or rates. That's actually really high. So that has been our goal. We've got a long history to make up for. We could shoot higher, but I think that becomes awkward or uncomfortable to shoot that high. So I hope that answers it. It's a strategic discussion about what seems fair and reasonable.
Yep.
I think for everybody, if you're well below that, people should be asking you, what are you doing? Because you need to get to something that is sustainable. But to have a 1% operating margin or 0.5% or negative is not sustainable. We are in an unsustainable mode, and we continue to work out of it, but we're doing better, and we're investing, and we're addressing a lot of issues. We used to have the oldest MRI, mobile MRI, probably in New England, but we replaced that. We've had, quietly been addressing some pretty horrific issues over the past 5, 6 years, but that's a good question. So that is why we sit there at that number.
Thank you for your explanation. And so you balance that number with the rate increase that you're going to charge to commercial payers, and you've come with the 4.6, which is above what the Green Mountain Care Board guidance was. So how do you think about the 4.6 increase in commercial rates as compared to your operating margin, your sustainability, and the investments you feel you need to make in your facility?
I think it's a fair and reasonable step in the right direction to get us better, because we've had literally a decade or two of low prices, and we've not even asked. I mean, this is not the Green Public Oversight Committee. I've been around forever. I love these old words, or Green Mountain Care Board. It's just that the hospital never even asked. And we would often ask for zero, we would ask for a negative. And so we have suffered a lot when it comes to many issues. So I think the 4.6% is reasonable. It does move us towards reference-based pricing so that we're all, I know that critical access hospitals are exempt from that, but we do need to really look at many of these levers. So I think that is important and helpful. If you cut that, then it's going to cut our operating margin, and we continue to sort of languish, and we're not really getting better. And we've cut a lot of services. We're continuing to look at how to be as cost effective as possible. So we're trying to address as many fronts as possible to get better as soon as we can. But thanks for asking.
Great. Thank you for your answer. Those are all the questions I have, Chair Foster.
Thank you very much. Member Holmes?
I think I'm set. Going last, I had a lot of my questions, all of my questions asked and answered. So thank you so much. Appreciate the presentation today.
Great. I'll turn to the healthcare advocate, Savez.
Thank you. Emma Zavez for the Office of the Healthcare Advocate. Just have a couple of questions. So over the last year, there's been a lot of talk about how to meet the essential healthcare needs of people in rural communities. Wondering if Copley has worked to define what it considers to be the essential health services that people in your community need. And if you use that definition of an essential health service when you consider closing service lines or adding new capacity, like the construction of the 4th operating room.
Yeah, I'm not familiar with using that. It might come up in our next go around of community health needs assessment, which are mandated or our strategic plan. So I don't think that has been front and center for us to say what our essential community health services. I know primary care is fundamental for every community. If you don't have access to primary care, you're driving people to an ER. That's very expensive. So I'd start with that. And ER, I think, is essential services for many communities if things do fall apart, which is unfortunate if it happens. So we have a variety of services that we provide, whether it's general surgery, foot care, orthopedics, neurology. So I don't really have an answer to that just yet, but I appreciate you asking. I'll have to consider it.
Thank you. My next question is, how do you calculate savings from participation in the New England Collaborative? And has Ovation Health or any other private equity-backed company approached you to enter into an affiliation for service line acquisition or other services?
That's another good question. We have direct details as to the expense reductions that we've had that we book and notice and can identify. As an example, we broke a longstanding relationship with a medical malpractice insurance company out of Maine, Medical Mutual of Maine, and we broke that relationship. Mimic. It was very difficult to do, but we're saving over $250,000 a year, and we've got a 2-year agreement with a new, sort of very reputable a newer startup medical malpractice insurance company. Some people are upset with that relationship break. I understand that, but you can't sit with the opportunity or dollar amounts that would save you money. So we are doing what it takes to make sure that we've got good coverage. We don't have any less coverage. We don't have any problems with deductibles. So we are trying to make those decisions, even though it is hard in small Vermont where relationships are important, even business relationships. I don't know of any venture capital group that would even be interested in Vermont, to be honest with you, just because it's really hard to make any money in Vermont. So the Ovation program has been in Vermont for a long time. They've been very helpful for us. They do primarily get us to an excellent position with a national group purchasing organization. They spend between 53 and 55 billion a year on annual supply acquisitions for healthcare. So it's been very helpful and promising. But I don't know of any. We've never been approached by anybody, but we're saving real money, and that's helpful.
I understand. Ovation is a private equity backed company. And I know it's maybe hard to clarify sort of based on the savings and all of that, but can you describe how much you're paying for the contract with Ovation?
For the contract for the collaborative,
Yes.
what is it, Jeff? Oh, 27,000 a year. Yep.
Thank you.
Yep. Okay.
My last question. So over the winter, the Vermont legislature debated capping the price of outpatient infusion drugs at hospitals across Vermont. And we heard from some hospitals that they would have to turn patients away. So I wanted to ask, does Copley have capacity to provide outpatient infusions to additional patients?
Jody,
I know there was consideration of and being able to take those patients on, so we were planning on it, trying to consider helping.
Okay, they can't hear you. So we're pretty busy. I don't know that we don't have capacity. I would have to talk to the folks that run the infusion chemotherapy program. We added some capacity to that. We're very busy, thankfully. And I know a lot of people prefer not to go to a tertiary care center regardless or leave their community. So I think the program's very successful. We might have some capacity. I assume if people want to come to us, I don't think we'd ever say no. So if somebody said, listen, I live in Richmond, I would love to come to your facility. We've never sort of said geographically no. So I think we're in pretty good shape. I think there's some capacity, but not a lot.
I will speak, Jody speaking. I know that they are thinking from a leadership perspective. The leaders were talking over that area, the infusion, the nurse practitioners, and with our pharmacy team to see how, and they were preparing knowing that was coming. So they are trying to see if they have the capacity, and they're aware of that change happening and trying to see if we can make space. So there is consideration for that and really thoughtfulness putting into that.
Yeah, if we've got the capacity, we'd love to fill it because it's just better use of existing staff, resources, fixed costs. So it's actually helpful to the system. And so that would be something we would say yes to, pretty much default. Yeah.
Thank you. That was my last question. Thanks so much.
Thanks.
Thank you for your questions. I'll turn to public comment via the raise the hand function. Vicki Rich.
Sorry, I'm not great with technology. I do people way better. Thank you for the opportunity to speak today on this platform. And I'm a registered nurse, lactation consultant, childbirth educator, and labor doula. So clearly my interest here is the closing of the birthing center. And I haven't seen it anywhere where the wider community extension referral system has even been looked into, and wanting people to think about pregnancy, prenatal appointments, postnatal appointments, and prior to discharge after birth are all golden touch points for people to be referred to all these community services, which most of them cite right into the community health needs assessment, which identified primary care, substance abuse, mental health, nutrition, dental care. All of those things are addressed with a pregnant couple right off the bat. And I would probably put in a bug for, my true wish would be do not close the birthing center. I think there's ways to keep it, and still I understand the financial issues going on a little bit, but I think it's doable. But at the very least, slow the roll. Why does it need to close in less than 10 months from the time it was even whispered and leaked through the grapevine that it was a possibility? That was only December and January, and here we are closing at 100% 10 months later. I think if we could be allowed a little bit more space and time to at least try to create a whole new system where the birthing center right now is the hub of a spoke of a wheel, And if you think of all the spokes that go out from the center of a bicycle tire, a bicycle wheel, give us some time. The people on the outside, I speak for all of those referral sources, the health department, the Lamoille Family Center, all the doctor's offices, all of these places. And we would need to collaborate and figure out how to move forward and get people the referrals they need and the coverage they need and the care that they need, which come up in the birthing continuum. I won't take up any more time. Thank you so much. I respect the work of everyone here and keep up the good work. Thank you.
Thank you very much for your comments, Ms. Rich. Tracy Curtin.
Hi, I'm Tracy Curtin. I'm a resident of Worcester. And this past April, I gave birth to my first child at the birthing center. I'm here to speak on the disturbing trend of closing these small-scale birthing centers for reasons of quality control. Healthcare decision makers are using a false narrative, I believe, that small birthing centers provide low-quality care to justify their closing, when in fact we know this is purely a financial decision that hurts birthing parents and makes maternal health care harder to access. I think we need to be open about the fact that a birthing center will not be a profitable building department of a hospital, or won't be a profit building department of a hospital. That's always going to be true because of the low intervention model. This can be true, and it can also be true that they should remain open. Maternal and child health care need to be prioritized over profit. Childbirth is not a specialty service. It's a core need that every hospital should be ready and able to serve. Importantly, this should not be served in the emergency department. I could tell you the story of my delivery at the Copley Birthing Center and how it got me off on the most empowering foot as a parent, but we can also look at data, the incredibly low C-section rate, the contrastingly high rate of midwives instead of OBGYNs as attendants at births, the lack of seizure history at the birthing center. All of these data point to quality. I'm a part of a large and growing movement of people who care about maternal and child health care, who see an enormous red flag as the decision is being made to close birthing centers, such as ours here at Copley. I ask you to rethink this decision and weigh the literal cost of keeping this department open in order to not be a part of a disturbing trend in the region and in a state that claims to want to support young and growing families. Thank you for your time and for your work.
Thank you, Ms. Curtin, for your very thoughtful comments. I appreciated that. And there's an important point there, I think, not as to Copley, I just mean this writ large, that with some of the budgets we see, there's often a request for finances for services that lose money. And as we go forward in transformation, we definitely don't want to see cherry picking and lemon dropping. It's got to be consistent with the state's transformation plan that the AHS is leading. April Vandeveer.
Hi, I'm one of the midwives at Copley, and I just wanted to cover a little bit about my job in order for it to be clear of what is being lost besides just the birthing center. So I do deliver babies, but about 2/3 of my job is spent in our clinic. And when patients come in for prenatal visits, I provide care that goes way beyond pregnancy. I help them apply for health insurance, quitting smoking, accessing WIC, SNAP, Reach Up, housing and transportation resources. I manage their hypertension and diabetes, diagnose their thyroid disorder, start them on medications for depression and anxiety, or help them access treatment for substance use disorder. These are all important things, and pregnancy is a time when patients are motivated to make lifelong changes to improve their health. Importantly, most patients I often see years after they have a baby because they know me and trust me with their care from the time they have a baby onward. And a lot of times they're the only people, I'm the only person they see for the whole year. So I might convince them to get their first mammogram, their first colonoscopy, check their cholesterol, give them their flu shot, screen for genetic cancers. Our office right now is a hub for thousands of patients to receive a multitude of services. And this November, Lamoille County is going to lose this care we have offered over decades in the community that already faces a shortage of primary care providers. This is important. Lastly, I'm sure some of you have seen the most recent research just released for August 2025 from the American College of Obstetrics and Gynecology, which looked at over 14 million births in the US and found that maternal care deserts, which means a county that does not have any OB unit, which Lamoille will become in November, has a significant increase in maternal mortality. We're closing OB units can cost lives, and this is not abstract or hypothetical, but a true increased risk to the lives of Vermonters. With Copley's birthing center closure, Vermont has terminated all of its, Copley has terminated all of its certified nurse midwives who as mid-level providers are efficient and relatively low-cost way to deliver comprehensive healthcare, especially in rural areas. And unlike far-flung providers outside of our community that could fill in, over decades, we've gotten to know the community resources and how to help our patients locally and how to access those resources efficiently and meaningfully, often the same day as they come see us for care. So in summary, I just wanted you all to know how much larger of a loss this is than simply a birthing center closure. And ultimately, it could be a huge drain of rural healthcare providers, as well as patient safety, access, and affordability. Thank you.
Thank you for making time to attend and share your comments, Ms. Van Devere. Ellen Schwartz. I'm sorry, Ms. Schwartz, you're muted.
I'm sorry, I thought I had unmuted. Can you hear me now?
We can, yes, thank you.
Okay, great. Thank you. Thank you for holding this hearing and for taking public comment. I'm actually here today testifying on behalf of the Vermont Workers Center and the Healthcare is a Human Right campaign. The press reports that we have read say that the closure of Copley's Birthing Center is being considered because the birthing center is losing money. I'm sure you're aware that this is part of a larger systemic problem, both within Vermont and nationwide. Just last week, the New York Times ran an article about the closure of labor and delivery services in rural hospitals, in which they stated that the biggest issue is financial. Hospitals typically don't earn enough from labor and delivery to cover the cost, which other folks have already referred to. Tracy and April just spoke in important detail to the value of Copley's birthing center and to birthing centers more broadly. Unfortunately, we're seeing this US model of operating healthcare as a business, including birthing centers, but not only birthing centers, operating healthcare as a business rather than a public good, fail at the expense of both patients and healthcare workers. We urge you to use a different rubric to guide your decision about the birthing center in particular and changes to our healthcare system more broadly. In passing Act 68 this spring, Governor Scott and the legislature entrusted the Green Mountain Care Board with additional authority to ensure that our hospitals and healthcare delivery system are fulfilling community needs and guided by Vermont's principles for healthcare reform, including ensuring universal access to and coverage for high quality, medically necessary health services for all Vermonters, and certainly the services of a birthing center would fall in the category of medically necessary. We urge the board to take this charge seriously. The strong support for the birthing center from community members and workers reflects the need it fills and its stellar reputation as a model of responsive, patient-centered care. This is an approach to care that should be expanded across the state, not shuttered. Please listen to these people who are directly impacted by the decisions you make. Basing your decision on community needs is a path forward to a healthcare system that truly addresses the right of all people to access the care we need. In addition to considering current community needs, we should be anticipating needs. We hear consistently that Vermont is an aging state and that we need more young people staying in the state and moving here. A consideration for many people who want to have children is access to high quality birthing care, such as that offered at Copley. If that care is only available in a few population centers, young families will be discouraged from locating in places like Lamoille County. Closing a birthing center is not a way to attract young families. I testified at your recent rate hike hearings where I urged you to use your power and platform to call out the crisis facing our healthcare system by calling for systemic change. The proposal to close Copley's Birthing Center is another symptom of the crisis. You are not legislators, but you can add your voice and expertise to those of us who appeal to our legislators and governor to take action about the pressing need for a healthcare system that prioritizes community health needs and puts patients and healthcare workers first. I and my fellow Vermont Workers Center members fervently hope that you will do so. Thank you very much.
Thank you for your comments, Ms. Schwartz. Representative Iacovone, thanks for being here. Nice to see you.
Good to see you, and thank you, Chair and board members. I want to start by making it clear that in no way are my comments around the Copley Birthing Center intended to discredit or disparage the hardworking people on the Board of Trustees at Copley. I believe they've worked earnestly and sincerely to fulfill their fiduciary obligations as they see them. I believe in so doing, however, that the broader needs of the community, the region, and even the state have not been looked at with the same robust nature, the way it should be. One thing, there are many unknowns, but one thing I know for sure, the decision to dismantle the birthing center will increase healthcare spending. It may lower costs for Copley. It will not lower costs for the state of Vermont. For those folks in our community who go to UVM to have their baby, the price paid by Blue Cross Blue Shield will be some $20,000 higher per childbirth. The price paid by Blue Cross Blue Shield at Central Vermont Hospital will be some $10,000 higher. And the stress on families who will have no nearby services to go to, an hour to go to Northeastern, an hour to go to North Country, an hour to go to UVM, 45 minutes to Central Vermont Hospital, at a time when they are most vulnerable and those in poverty. It will extract a heavy toll, a toll that may not be measurable on balance sheets, but truly it will bear heavily on these families. I look at this issue, and as your board has too, in its questions over the last several weeks, and I ask myself, what can we do to further reduce administrative costs before we have to reduce clinical services? And I'm appreciative that Copley is working hard on their shared services, but I would challenge us to go even further. Could you imagine North Country, Northeastern, Copley, all having one shared CEO, one shared CFO, one shared HR director, one shared IT director? Could you imagine a management team overseeing these hospitals instead of one at a time for each one? Who could look at those kinds of costs? And could we also further imagine that as the strategic health plan is developed as envisioned in Act 68, could these kind of administrative services be looked at? My request to the board is that you work to defer, to delay any decision on the Copley Birthing Center until a strategic health plan is developed, so we can see if this type of decision would even comport with a strategic health plan as envisioned. I would also ask that Copley revise their community health needs assessment to see how a community without a birthing center would be impacted and what would need to be done. I think all those things are important and need to happen first. In closing, I do want to, and I will submit the petition on your webpage electronically with some 2,700 signatures of folks in our community who want these services to continue. It speaks volumes to the level of passion around this issue and the deep concern they have. Thank you for this opportunity and thank you so much for your hard work.
Thank you, Representative Iacovone. And your comment about shared back office and administration across hospitals is something I and we can imagine. In fact, it's a concept. The board initiated a series of meetings with healthcare leaders starting on May 1st of this year because we were really concerned about the upcoming rate requests. And so we asked healthcare leaders across the state to come up with $200 million of savings. Unfortunately, that hasn't materialized, and now the board is in a position to make some really hard choices. But one of the concepts that we did throw out as something to consider was that shared back office administration, as you described it. I don't think it's going to happen anytime soon, but it's something that I think is being discussed and considered and maybe does need to be looked at. So thank you for your comments and for attending today.
Thank you.
Kim McGinnis.
Turn mic on. I think, okay, camera. Allow. There we go. Hi there. My name's Kim McGinnis, and I just wanted to speak on behalf of my recent experience with childbirth because I think it really illustrates the need for the Copley to stay open. I apologize for the background noise, but I'm making this work. So I'm a mom of two. I have a toddler and a newborn. I'm definitely going to start crying because I'm still processing this whole thing. I live about a mile from Copley, and I got there with 11 minutes to spare before my son was born. I'm just going to breathe for a second. So I woke up on July 1st, his birthday, and I was going into labor, but it started very slowly. So I was up and about. I was, cooking breakfast, chasing my toddler, and it was fine. And around noontime, I got in the bath to calm down, and it all of a sudden intensified. And I suddenly couldn't stand without triggering a contraction, and I was very scared that I was going to deliver on my bathroom floor. So I got there, and yeah, within 11 minutes, my son was born to a mom in complete shock of that it just happened. And I just really fear because if this happens to somebody else, I'm just imagining like I might have gone to Montpelier or something, the hospital, and I would have given birth on the side of the road in a hot car with no cell phone reception. And I'm just, I understand that the profits need to stay, like you have to consider profits, but when it comes to childbirth, it's not something that makes sense to regionalize because try as we might, we can't plan it. So I don't understand how this is a step forward for our community. I don't understand how data is being interpreted, but I really urge something different to occur. And with you constantly referencing low cost, and I just want to say when you have health insurance, which I do, and I pay for it, I pay like $3,400 a month for my family of four. Your deductible is your deductible, and I would think that with that much of a cost, that something else could be taken when the cost of health insurance is so high, childcare is so scarce, and now you're going to take my birthing center. I am very concerned. So I just wanted to share my story because I think it really illustrates why it needs to stay open. Thank you.
Thank you, Ms. McGinnis. And I'm glad that you and your children are well and safe and that you had a positive experience. And thank you for commenting. Anne Marie Dryden.
I want to thank Kim for sharing her story. That was really brave and really moving. I am a nurse practitioner in Morrisville, Vermont. I was formerly an OB and L&D nurse at Copley, which seems like a lifetime ago, but I also am a family nurse practitioner and a current practice in psychiatry. So I'm really glad my last appointment canceled so that I could be here. I have a few bullet points that only support the well-informed advocates that have spoke before me, who have spoken. Could speak to the U.S. maternal mortality rate that outstrips most industrial nations, and lay a bunch of statistics down regarding how much time a woman who abrupts the placenta abrupts has before bleeding out and dying, or how long a child who is born and can't breathe might have before it needs care, before it too dies. I could ask again about the governor's mission to bring working young families to Vermont and how a town thrives if families don't want to move there because there's not a safe place to give birth. I could expound upon the essential care that the nurse midwives provide in our community when seeing a PCP takes months to a year to be seen, or the rationale behind surgeons making $750,000 annually and the loss of a ravage of 20,000 per delivery, quoted in a recent article, is the justification for closing an essential community resource. But rather than get into all of the technical or statistical, I want to leave you with a human story, because I think Kim's reveals that's what we're talking about, how this impacts patients. I've been a nurse since 1990, which seems like a really long time, I guess. 35 years is. It's been a long career as a patient advocate first. Patient safety. And that's where I think a lot of my frustration and passion comes in this particular issue. My niece was born April 10th, 24 weeks gestation, because her PCP thought my sister might have been having kidney stone. But in the middle of the night, she went to Copley to be examined because she just didn't feel right. And while my sister was waiting for the obstetrician to assess her, my niece was delivered into the doctor's hands and just about barely fit in his hand. So what do you do with a 24-weeker at Copley Hospital? Well, you get nurses and anesthesiologists who really know what they're doing, and they deliver the care that that baby needs so that she could be transferred to the medical center, keep her alive. Except on that April 10th, we had a blizzard and she could not be transferred for several hours. But the providers at Copley delivered incredible care. So incredible that her neonatal 100-day stay was incredibly unremarkable for a preemie born that way. And she's now a 10-year-old thriving at Stowe Elementary School here in Lemoyle. Smart, bright, with promise, and who knows what she'll bring to the world. That would have been a very different story if we did not have our local community birthing center. It's a very personal one, but I am not the only one in this community who've had close calls with deliveries. I myself had a very complicated first pregnancy. My baby didn't survive past 37 weeks. But the care I received at my local birthing center with my neighbors and the people who knew me really help to measure that pain and create an experience that wasn't worse than it had to be. So I don't understand why orthopedics, for example, or administrators are able to get paid the exorbitant salaries that they can be paid, and yet we can't figure out how to make birthing care, maternal care, newborn infant care sustainable in one of the fastest growing counties in Vermont. So I would ask this board and the administration to, outside the box perhaps, but I don't think that this approach is really what's in the best interest of Vermonters. It's certainly not in the best interest of patients, their families, and their safety. And with that, I thank everyone for the work that they're doing here, and look forward to hearing your follow-up. Thank you.
Thank you, Ms. Dryden, for sharing those really impactful stories. Jade Kaplan.
Thank you. Hi, I'm a nurse midwife. I work in St. Johnsbury. And I've been working as a nurse midwife in Vermont for 23 years, and I've been working as a nurse midwife throughout my career for 36 years. I've been to a lot of places, and I've seen a lot of stuff. I have a degree in both a master's in nursing and a master's in public health, and I have worked a lot in epidemiology, and I really enjoy using statistics to understand situations and issues, clinical, political, policy, any of those. And what I know from doing a lot of work with statistics and in epidemiology is that it's very common to manipulate statistics to support a narrative that you are invested in. And I think that this may have happened when the messaging came out from Copley that a reason and a justification for closing the birthing center was that because more than half of the people in Lamoille County were choosing not to deliver at Copley. And that is, it sounds terrible, but it actually is a reflection of the realities of what women do to get to the care that's closest to where they live. So counties don't fit neatly into hospital proximity. Some families live in Lamoille County, but are closer to other hospitals. And while we also receive significant numbers of patients at Copley from outside Lamoille County, such as Hardwick area, others, such as people from Chittenden County, will specifically seek Copley out as an alternative to UVM. So women will cross town lines, they will cross county lines, they will cross state lines, they will cross rivers, they will cross creeks, and they will go over mountains to get to a facility that is either closest to them, or if they have the resources, to get to the hospital that they prefer or where they feel safe, or where they need to be for the level of risk that their pregnancy requires care for. It's important not to omit these women from the data when you are talking about the use of Copley's birthing center. Copley in 2023, based on birth certificate data, 60% of the birthing women were from Lamoille County. And another 40% were from 5 other counties. Women drove to Copley 40% of the time to have their babies at Copley from another county. And I think that's important to know. Also, 45% of the women in Lamoille County did deliver at UVM. That is less than half of the county went to UVM to have their babies. And you have to keep in mind that we have rising levels of poor maternal health in this state. We have increasing obesity, increasing rates of hypertension, increasing rates of gestational diabetes, And Copley, along with the other critical access hospitals that have maternity centers and midwifery services, are level 1 facilities. So these women need to go to a tertiary care center and have their babies, and that will be either UVM or Dartmouth. I think that you need to keep in mind that all of Vermont's rural counties, about half of all the deliveries in each county are from within their county, and then the other half are going to come from several other counties. This is a normal finding in the data for rural healthcare and is likely true for all services, actually. In addition, some families in Lamoille County need this higher level of care. It's not that they choose to deliver elsewhere always, it's that they should and need to. So although they would love to stay in their community, sometimes UVM is the most appropriate place for families to go when there are higher risk issues going on with the pregnancy. So I just wanted to speak specifically to the data and in support of the idea that perhaps the Green Mountain Care Board can somehow create a stay of closure. And if they cannot, to at least be educated on this issue if other facilities begin to talk about the need to reduce their maternity care centers in order to meet budgeting criteria and requirements that are coming up to cut expenses and that sort of thing. Thank you for listening to me, and thank you for everyone else's very moving and important presentations.
Thank you very much, Ms. Kaplan. Mr. Del Trecco?
Good afternoon, Chair Foster. My comments aren't specific to the birthing center nor the Copley presentation. So I could submit my comments via mail or a written comment if you'd prefer, but I would like to say a couple of words anyway.
Please take your time.
Thank you. As we just heard, healthcare is super personal. It's emotional, and the decisions we are making as healthcare leaders in Vermont affect Vermonters in unique and different ways. So I want to acknowledge this work is never easy. I want to extend my appreciation for the members of the public who spoke up today. It takes some guts to do so, and their comments were personal, and so thank you for sharing. I also want to thank you and your staff and the hospital teams for the work leading up to these budget presentations. This work's a marathon. You all know that. It shows dedication. It shows the willingness to hear public comment. It shows the willingness of hospitals to think differently. And I know this work has just begun. I also want to acknowledge you all streamlining the budget process this year and exempting 3 hospitals. And I think what we heard over the course of the last week and this week, that hospitals understand the inflection point we're at. We're not leaning back, but we're leaning in, and this work's not going to be easy. As I outlined at the beginning of these hearings, we've done very well in meeting the terms of the guidance, and I won't go into those details, but I will comment in the space of doing more work. As discussed Monday, one of the things that's being explored with Mike Smith and as the liaison to UVM is options and for pricing and caps or referencing to Medicare. I want to acknowledge and point out the payments for many reasons are very important, whether it's affordability, the access we just talked about, quality, and providers. It's so important in so many different ways, and that's just the tip of the iceberg and getting that right. So with that, I want to make sure that you hear and the public hears that VAS and our members is ready and want to serve as a resource to you, the board, the Green Mountain Care Board, and DFR to help evaluate that. And in so many ways, we can start to do some of this work and make some of these big decisions. So as I stated at the beginning of our hearings a week ago, or more than a week ago now, we're committed to evaluating everything and opportunities to improve operations, patient care, Vermonters deserve that, and it's our collective responsibility. I also think as we examine each of these things, we want to know the pros and cons of each opportunity, and we need to continue to seek the best pathway forward to implement these changes. So again, I appreciate all of the work that's happened over the last couple of weeks, and as I said, so many ways. We're just beginning. We have deliberations. We have big decisions around healthcare reform and transformation and operational expense adjustments. So thank you to you and your team, and I will end my comments there. Thank you.
Thank you, Mr. Del Trecco, for attending all the hearings and for sharing your comments and views and for your members' work. This is our last hospital budget hearing. Deliberations will be coming up soon. I did just want to acknowledge the work that the hospitals have done in preparing their submissions. I think really reflecting more so than any prior year, the serious challenges we face and a recognition of that. And I acknowledge that and appreciated it. I want to thank the board members also for their hard work. It is a marathon. There's a lot of material that people have to get through in a tight time period to just be prepared and to conduct a hearing and hopefully ask questions that allow us to make the best decisions. And certainly last but not least, our hospital systems finance staff. We have a new director this year, Matt Sutter. He did an outstanding job, as did his entire team. It's a small team. It's 4 people. And they work tirelessly with the hospitals to get the data, to collect the information with the board, to ask the right questions. And every night in this stretch, they're up very, very late and working really, really hard. So I just wanted to acknowledge that and thank everyone for all of their significant efforts. And then there's a number of people for us that manage the board hearings, the court reporters, the public, the media. There's a whole lot that goes into trying to do this and to make sure it's a transparent process where we get the public's engagement. And I guess very last, I did want to thank all of the public that attended all of the hearings and provided feedback and input. It's an incredibly important piece of our process, and I highly value people taking time out of their lives and their days to help us do that. So that concludes our hearing portion of the hospital budgets. We will continue working and trying to get to our deliberations. So with that, I'll ask if there's any new or old business for the board. Hearing none, Mr. Miller, thank you for your work as a court reporter, and I will move that we adjourn.
Second.
All in favor, say aye.
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 Aye, and we are adjourned.